Yes, ma'am, that's right.
Yes. So we can start. We are live.
Uh, just a second. On what YouTube channel are we live?
Sir, I will forward the link to your phone number.
No problem, sir. No problem. You can call me Dhruv. Absolutely fine.
But she's your friend, right?
Sir, can you please mute your mic?
Sure. I'll do that.
Requesting the participants also to please mute your mics. Thank you. So good evening and welcome to this national webinar at Believers Church Medical College and Hospital. This is our 48th webinar. And today our topic is a very, very, very important topic, and it's about a novel field. Something which has been there for centuries, but something which is being developed into a totally separate field. So yes, pain management is the topic for the day. And to speak to us and to throw more light, we have with us Dr. Dhruv Bibra, who is working as senior consultant in pain medicine at the Delhi Pain Management Center. Now, this hospital is one of a kind in the country, and they are growing into more and more centers. So, sir has been trained in pain medicine after graduating in Gujarat, Karnataka, and New Delhi respectively, and he has trained in pain management under one of the pioneers of pain management. So after training in DNB anesthesiology in Batra Hospital, he went on to do his pain management. 2015 onwards, he has been consultant pain management, a physician with an average OPD of 450 to 500 per month, interventions of 75 to 100 per month, research projects of 1 to 2 per month, and teaching 4 students at least a month. So this is what our speaker is all about, and he has more than 22 publications to his credit. His areas of special interest are fibromyalgia and neuropathic pain syndromes, regenerative medicine, developing screen tools in context to the Indian subcontinent, spine, pain, prevention, treatment, and rehabilitation. So, sir, it's a great privilege to have you in our midst to share more insight into this particular topic. So, welcome, Dr. Dhruv, sir. And to moderate the session, we have our very own consultant in palliative medicine, Dr. Ligia Matthew, madam. So she had completed her MD in anesthesiology at CMC Vellore, and she has trained in palliative medicine at the prestigious Cardiff University, Wales, UK. And she is currently taking care of the palliative care department, and she has a vast experience in chronic pain management. So, ma'am, it's a great privilege to have you on board as the moderator. So, over to you for the overview of the topic and handing over to our esteemed speaker. Over to you, Ligia, ma'am.
Good evening to all. At the outset, can I just ask those who have not muted to please mute your microphones? So thank you, Dr. Jacob, for that warm introduction. And today's session is on a topic which is very close to my heart. We all know that inadequately treated pain remains a global public health problem. Attitude towards pain, that is accepting pain as part and parcel of our life. Inadequate training in pain management during our basic medical education. Misconceptions about pain medications and under-prescription of these drugs. All these are factors which act as barriers to adequate pain relief, leading to unnecessary suffering in millions of patients in our country. With major improvements and newer developments made in the field of pain medicine, it is unacceptable, or I would like to say unethical, to let any patient who come to us to suffer in pain. So today we are fortunate to have in our midst one of the experts in this field to enlighten us on various modalities of pain management. So once again, I welcome you, Dr. Dhruv Bibra, and we are all eagerly awaiting to listen to you, so I won't take any more time. And at the end of the talk, we'll be taking questions. So if you have any questions, you can post it in the chat box, and we will address it at the end of the session. Thank you. And over to you, Dr. Dhruv.
Thank you so much, ma'am, for the warm welcome. Can I start sharing my slides, ma'am?
Yes, please.
Thank you. Just to go, are my slides visible, ma'am?
Yes, yes, it's visible.
Am I audible, ma'am?
Yes.
Thank you so much, ma'am. So can I start, ma'am?
Yes, yes, please.
Thank you so much. So thank you so much for the warm welcome, and thank you so much for the warm words. In nutshell, I happen to be an ardent student of pain medicine. That is how I like to introduce myself. I would like to thank the principal and the management and the organizing team for organizing this kind of a webinar. It is not very frequently do I get to speak specifically in a medical college where we have an audience of right from undergraduates to postgraduates. Generally, we are restricted to the postgraduates training programs, and I have got postgraduates or post SRs who come to us for their training. So it is always a wonderful experience to talk to the young minds, young medical minds who are going to shape the medical future of our country. I will also like to thank Dr. Philip, who was one of the mentors in my postgraduate days. He was a generous person, right? During that time, also a decade back, and now also, he introduced me to the management and gave me this opportunity to talk about. So thank you so much. And I can tell you that the basic principles of putting in a needle, which I practice day in and day out, somewhere down the line, he was gracious enough to tell me the fundamentals, and the fundamentals remain the same. Only the techniques changes. So with that, let me start with pain medicine. It is a new emerging super specialty, and I will be discussing about the scope, the challenges, and giving you an overview of all the wide spectrum of things which are there, or various modalities which are there which are coming up in the field of pain medicine. Okay, so now pain. Now pain may have different words to describe them across the length and the breadth of the country and way beyond. But all of you will agree that pain per se is a kind of an agony and a suffering. And we are just here to discuss about that. Talking about the word pain. Now the word pain was first, it is derived from the Greek word poena, which means penalty and punishment. And my dear friends, people who suffer from it, and most of us have suffered with this pain some or the other part of our lives, and you will agree here that it is definitely a penalty for the people who suffer from it. But how old is pain? Now pain is as old as mankind, and it is said that even Eve had to go through labor pains. But in spite of being such an old medical phenomena, it is one of the most or what I should say understood, because of the complexity involved, which makes its diagnosis and managing the patients of pain a big challenge. And then you have these things which make it more mysterious when it comes down to bearing pain and suffering in pain. So before we move to the future, let us go back to the past and see how the pain medicine, how it all started. Now, pain medicine, it was started by Dr. J. Bonica, who was an American. He was a doctor. He was serving with the Allied forces during the Second World War. And he was given the job of taking care of the pain of the injured soldiers. And what he realized during his stint in the Second World War, that he was ill-equipped or ill-trained to take care of the pain. He understood the multi-dimensional pain, the complexity of the pain, as we know as we know, and therefore, for the very first time after the World War, he started studying it, and for the first time introduced the concept of a pain clinic, especially a multidisciplinary pain clinic where doctors and staff of various specialty was clubbed together and brought under one roof. And he is credited to start the very first pain clinic in 1964 in Seattle, US. Along with that, he wrote a lot of books. He was also the founding member of the largest pain organization that we know, that is the IASP, International Association for Study of Pain, which is one umbrella organization where we have right from basic basic researchers right up to interventional pain physicians, all under one or umbrella organization. And along with that, they come up with a lot of guidelines and definitions, as I will be going through later in my talk. Now, pain medicine as we know today has been thanks to this gentleman, Dr. Prithviraj, an Indo-American. Now, where Dr. Bonica was more about multidisciplinary approach, Dr. Prithviraj was the one to introduce the concept of interventional pain. Now, what basically is interventional pain is, I would like to explain it with an example, is that it is something where we are trying to identify what is the pain generator. With the help of some sort of an imaging, we are trying to deposit the highest concentration of the drug. For example, if the patient is having, say, a back pain, and the cause of that back pain is a disc or is a facet joint. So what we can do is we can introduce a needle there, deposit the drug. Now, the choice of drug, how we the imaging that we are using, that is evolving, but the basic concept is trying to find out the pain generator and then targeting it with a set of injections or a minimally invasive procedures. Now, that is what interventional pain is all about. And the person who started it, or who was the founder of this, was Dr. Prithviraj. So this is what we are following these days. But at the same time, when I'm trying to talk to the young impressionable minds, I would like to reiterate, I would like to repeat itself. Pain medicine is a lot of time equated with interventional techniques and intervention. It is just a part of it, but not the entire spectrum. Now, talking about the history of pain medicine in India, now we were not very far behind. In 1968, we had Dr. Bhattacharjee, who started the first pain clinic in India at Safdarjung Hospital, Delhi, which is now the Vardhaman Medical College. Now, he was credited to have the first, but somewhere down the line, we lost track, and still we are struggling to find a good hold of in the field of pain medicine. Even the primary institutes have not been able to establish proper pain departments, but gradually and steadily the situation is changing in our entire country. And these kind of interactions that the one we are having right now actually goes in a big way in establishing these kind of departments in the in all medical colleges. Now, the person who was taking care, or who started the interventional part of pain medicine, or who revived pain medicine, was Professor G.P. Dureja. He was with the All India Institute for 21 years. Then he founded the Delhi Pain Management Center. And I was fortunate enough to work initially under him, then with him for the past decade. And I have been active, I have been involved for the past decade in interventional pain medicine. And it has been quite a fruitful journey. Now, since the history of the point, the question I'm often asked is, why do we need to study pain? Now, pain is taught in all these specialties, so why do we need a particular specialty? So I'll try to give you a perspective that if you see the OPDs, the patients who are coming to us, around 80% of them have pain as their primary complaint. It is the number one cause for which the person is seeking healthcare. Overall, it is the third most common cause for which a patient, the most common healthcare problem that we face. Along with that, it remains to be a poorly understood, complex, multidimensional, with biology, psychological, and social components attached to it. Okay. Now here I would like to explain this a little bit further. See, the thing is, how we as doctors tend to see pain is that patient has a fracture, there is pain, we take care of the fracture, the pain goes. But my dear friends, you have to understand that once the patient has fracture, he has pain, but because of that pain, he is unable to do his professional job. He is unable to fulfill his social commitments. And when these things happen in an ultra competitive today's time, it is bound to cause some sort of psychological effect on it. The patient might become anxious. For example, I often get sports person who are uh, who get injured on the field. Because of that injury, they are not able to play for a certain time. So there, if we just if we take care of the biology, or if we just take care of if we just try to take care of the pathology, our management will not be comprehensive. We have to understand what are the implications of that pain on the various aspects. Therefore, whenever we are taking care of patients of pain, empathizing with the patient and looking at pain at all the aspects where we talk about biology, the psychology, and the social factors. Now, let us talk about in numbers. You must have gone through a lot of literature which is coming about all the chronic conditions, whether it is diabetes, whether it is coronary artery disease, or even cancer. But surprisingly enough, the maximum amount of the highest percentage of global prevalence is for chronic pain. That is 26%. Interestingly, we also have, I was part of the study team which did a point prevalence study for finding out the point prevalence of chronic pain in India. And interestingly, we had a 30 to 33% of patients who had some sort of a chronic pain. Now, if you divide it, if you find out, if you go into the exact number of 35% of a population of 1.3 billion, the numbers are enormous. Fine. Therefore, my friends, there is a huge number of patients who suffer from some sort of a chronic pain for which they are struggling. Therefore, getting these number into perspective, we need specialized centers or specialized infrastructure which is developed to take care of this pain or take care of these patients. Now, pain clinics can be of two types. One, which is being run successfully at your institute, where like any other department of the hospital, you have a pain department where there are a set of doctors, there are nurses, there are paramedics who take care of it. And the second kind of a pain clinic is something what we are running, which is a standalone pain clinic where the patient is either referred to us by our other colleagues or the patient does a walk-in. Fine. So, but we need dedicated infrastructure where the pain is studied and introduced, is studied, and the patient is taken care of within the same roof. Now we talked about the number of patients, we talked about the infrastructure, but at the same time, to run those infrastructure and take care of that number of patients, we need specialized manpower. And the specialized manpower is going to come when we give a certain level of proficiency, clinical proficiency in the field of pain medicine, for which we require pain medicine to be developed, to be nurtured as a separate super specialty. Because we need a good trained manpower who is able to who is able to take care of the patient in pain in a holistic manner, who is proficient to lead a team of nurses, the paramedics, and junior doctors to give all aspects of chronic pain relief and rehabilitation. So what we need basically is a doctor, a super specialist who understands pain clinically, interventionally. Then he is supported by physical therapist, psychotherapist, occupational therapist, and dedicated nurses so that he is able to take care of his patients. Along with that, we also need some basic research. You have to understand that it is relatively a new field which started less than, say, 70 odd years back. Therefore, we need basic research, clinical research, a lot of pharmacological agents research, and interventional research, which needs to come into it. So we need those researches. And for that also, we need to have pain medicine as a super specialty. Along with that, we also need to have what I am trying to do, patient education, the education part. So we need pain medicine specialists not only to take care of the patient, but also to train the next generation of doctors and to sensitize the other budding physicians about pain medicine and chronic pain in a comprehensive manner. So that is why it is the need of the hour to have pain medicine as a super specialty. So now we all know the numbers, the infrastructure, and the manpower requirement. Now I'd just like to give you briefly about the few definitions or the ambit of pain. So starting with the definition of pain. Now this definition of pain is given by ISP, and in 2020 they revised the definition and they came up with this definition, which says that it is an unpleasant sensory or an emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, we know that it is a sensory phenomena, but what we do not know or we do tend to ignore is that it is an emotional experience. Fine. So apart from being a sensory experience, it is also an emotional experience. That is point one. Point number two, it is a personal experience. You cannot go for a generalized thing. For example, the people who are attending, if I hit you or pinch each one of you will have a different VAS. So the biggest mistake that we doctors do is we try to label the patient that this particular condition will only cause this much amount of pain and you are faking it. So that is wrong. Pain is a personal experience which is based on the biology, the psychology, as well as the social factors. Fine, that is one. Secondly, pain and nociception. Now, people who have been studying about pain, they will understand there is a nociceptors. Stimulation of nociceptors called a nociceptive pain. But pain is not only associated with nociception. So these are two different individuals. And as I said, that expression of pain will depend upon what has been their life experiences and the concept of pain. Fine. So always remember that apart from being a sensory experience, it is also an emotional experience. Now there have been various theories. I will not like to go into all of them, but what we are following right now is the biopsychosocial factors, a biopsychosocial model of pain. Now, in this model of pain, what I have been trying to describe, what I have described earlier also, that rather than discussing pain just as biology or the pathology, we have to take care of what is the psychological responses, what is the impact on his social life, and what are the pain responses. So an amalgamation of all those things need to be taken care of when we are assessing the patient, when we are managing the patient, and when we are doing a follow-up. For example, you must have seen that we see a lot of patients. Patient had an advanced osteoarthritis of the knee. The patient undergoes a TKR, a total knee replacement. Post that replacement, the patient says that I cannot walk. Now, during the assessment, we will realize the patient says that I have pain, and because of this, I cannot walk. Post surgery, we got the new knee, but the patient is unable to walk. So what we did was, we just took care of the biology or the pathology. We didn't take care of the patient or the condition as a whole. We did not emphasize the patient that there is a post-procedure rehabilitation, there is something like a psychological improvement, occupational improvement, there are certain lifestyle changes the patient needs to take care, and then gradually the patients will get back to his life. Therefore, while assessing it, while managing it, and now if there are some psychological elements which have been there because the patient has been suffering from such a long time, we need to address them also during our management. So just taking care of the biology, we have a knee which is deformed, we replace it, is not going to work. We have to start the pre-procedure rehabilitation in means of physical therapy, in talking about the psychological, which can be again with pharmacology and other interventions. Then the pathology is taken care of, and then again during rehabilitation we assess it and emphasize regarding it. So this is what is the comprehensive, multi-dimensional, multidisciplinary pain management, what I'm trying to talk about. As I said, we take care of biology by medications, exercise, procedures, the interventions, and sleep. Psychological, we need to talk about cognitive functions, emotions, behavior, what is it, attention. Social, what is this impact of this pain on his social, personal, and professional life. Now, with these things, WHO, this is also something very interesting, because WHO, we have been in a traditional teaching, we have been always taught that disease, that pain is a symptom. But WHO, what they did was, they said that chronic pain is a disease of the nervous system, not merely a symptom of something else. Okay, therefore we need to treat chronic pain as a disease rather than a symptom. And then there have been significant things where they talk about that pain relief is a human right. Then there have been accreditation societies which have talked about that it's the fifth vital sign. So therefore, any patient who comes into a IPD or OPD, you need to measure the pain score of that patient. Now, there are various ways of classifying pain. So based on the, this is something new which came in the Pain Journal 2020, which they have broadly described pain into 4 categories. One is the nociceptive pain. What I mean by nociceptive pain is the pain which is occurring because of the stimulation of the nociceptors, which is also called the physiological. Then we have got pain which is secondary to the inflammatory processes, like osteoarthritis, spondylitis, any sort of infection. Then we have got a neuropathic pain. Now, neuropathic pain, interestingly, is a pain which occurs because of disease or lesion of the somatosensory system. Just give you a basic example. Lesion would be something like a nerve injury, something like a herpetic neuralgia, something like a radiculopathy. Whereas disease causing nerve problem would be like diabetes mellitus, like cirrhosis, chronic kidney failure. And then very interesting, very challenging, which is the dysfunctional pain. What is a dysfunctional pain? Now, dysfunctional pain refers to those clinical conditions where there is no apparent stimuli. I repeat, where there is no apparent stimuli, but the receptors fire without any stimuli. I repeat, there is no external stimuli, but because of the dysfunctioning of the receptors, there is a pain condition. These are again very difficult to understand and difficult to treat. But one of the most common things, something like fibromyalgia, CRPS, myofascial pain syndrome, and irritable bowel syndrome. Now, this was one way of describing pain. Now, there are other ways in which we can also classify pain. Now, that is based on the physiology, which we have just discussed, then intensity, mild, moderate, severe. Now, for that, we need to measure pain. The most you can follow any scale that you are comfortable with. Then the time course, that is acute and chronic. Acute is any pain which is less than 3 months. Chronic is which is more than 3 months. Then what is the tissue which is involved, whether it is skin, which is muscle, viscera, joint, tendon. And then there are syndromes like cancer, fibromyalgia, migraine, and others. Now, this is something which I really want to touch upon, is that there is a misconception that all acute pain is a nociceptive pain. I repeat, all acute pain is a nociceptive pain. This is a misconception. And all chronic pain is a neuropathic pain. No. You can have a condition where you can have an acute neuropathic pain. At the same time, you can have clinical condition where a chronic pain is a nociceptive pain. In fact, in most of the clinical scenarios, you will have both which are present. Now, because most of you would be dealing with chronic acute patients, you will see that even in a preoperative or postoperative, in preoperative and postoperative areas, postoperative times, we have moved on to multimodal or multi drug regimes, that even now, in if we are, even for example, a patient is undergoing, say, abdominal surgery, there are studies which talked about starting a neuropathic agent, a pregabalin or a gabapentin, before the surgery, or TKR, for example, or a shoulder surgery or a spine surgery. So they take care of neuropathic pain by starting a neuropathic agent. And once you have a nociceptive stimulation, or during the start also, if there is nociceptive, so we go for a combination of a neuropathic agent. Along with that, we put an NSAID. Same for us also. For a very long time, radiculopathy was just associated with acute pain. So acute radiculopathy is a classical example where you have nociceptive stimulation also, as well as neuropathic symptoms also. Therefore, the drugs that we are using also is a combination of nociceptive and neuropathic. Now, these are the common types of pain conditions that we come across. One is neuropathic pain, then neuralgic pain, musculoskeletal pain, vascular pain, central pain, and cancer pain. Now, though it is now, clinical history forms the basis of medical education across the specialty. But when it comes down to pain, it is the backbone of diagnosing a patient of chronic pain. As you go through more and more clinical pain conditions, you will realize that we have to rely just on the history of the patient in diagnosing that pain condition. Therefore, taking a detailed history, nothing fancy, just the simple basic clinical history which we have been taught during our med school, have to be followed. Talking about chief complaints, the ODP, the comorbidities, everything as per what we have been told in our undergraduate days needs to be followed. And I tell you, no expensive investigations, no fancy thing can replace it. So therefore, history is the most important thing when it comes down to taking pain in the history. One more thing, as I said, that history is very important, because most of the pain conditions is based on self-reporting, based on certain criteria which are taken from the history. For example, history of migraine, history of fibromyalgia. Now, these are just based on history and personal experience. Therefore, taking an history is extremely important. That is one. Secondly, is a subjective experience, which I have already been told. And currently, the treatment that we have is more of an empirical treatment rather than a very specific treatment. Now, with that, I will just like to lighten the mood by saying, giving you my small anecdote or my own personal story. I've been married for last 9 years, and before that, we were going around for 1 year. So I know my wife for a decade now. But today also, whenever I come home, so I don't know whether I will be greeted by a smile, a hug, a frown, a scolding, or just hitting. So the same inconsistent thing is somewhat there with chronic pain. Most of the times, I'm also not able to find out the reason. In same way, you cannot always find out the reason or an anatomical explanation for this chronic pain. Therefore, my friends, who have developed an interest in pain medicine or who want to pursue pain medicine, be comfortable with that uncertainty. You will not be able to explain everything anatomically or say physiologically, because chronic pain is consistently inconsistent. Therefore, I also have embraced the uncertainty, and people who are in any sort of relationship will understand the uncertainty is there. Even with me, if you talk to her, she might say the same thing about me. So just be comfortable with that uncertainty when you are seeing patients of chronic pain. Now, we tend to measure pain. We try to quantify pain by these scores, which are the VAS or the NRS or whichever scale you tend to follow. Then these are specific questionnaires which are done to diagnose neuropathic pain. And I would strongly recommend that that can be done at an institution, and you will get interesting results. Is that whenever a patient comes to you with a complaint of pain, you can ask them to fill this simple questionnaire, which is the DN4 questionnaire. It is a very simple questionnaire, and you can get the incidence of neuropathic pain. Now, once we have diagnosed it, let's talk about the management of pain. Now, management of pain, as I told, it is multidimensional. So I'll be talking about those things which we as pain physicians can do. One is pharmacotherapy, the choice of drugs, interventional therapy. Then you have physical therapy, psychological therapy, occupational therapy, and sum total brings about a positive change in the patient. I wouldn't be going much. I won't be going into the details of pharmacotherapy. I'll be moving on to talking about interventions. So people who are just listening for the very first time about interventions is, now interventions is a set of specialized injections in which we firstly by history and history examination and investigation, we pinpoint what is the pain generator, and then we tend to target them with set of injections, and we aim for the maximum precision. Okay, so those are called interventions, or in layman terms, injections. So when do we do interventions? When there is inadequate relief, when there is no pain relief after conservative management. Second, the patient wants rapid pain relief. There is an absolute contraindication for any sort of surgical intervention. There are some conditions for which intervention is the only answer. So there is drugs and there is no option of surgery, there is intervention. Patient in today's time, you have to value the the opinion of the patient. If the patient is unwilling for surgery, then intervention can help him out. Coming from where financial constraints can be a big issue, even financial constraints sometimes goes in favor of using interventions rather than going for a surgical opinion. Now, I will move. The further discussion will be in the form of a case-based discussions, where I will be trying to give you the entire horizon or the entire gambit of things which we can do or which we are doing in pain medicine. Starting with a very simple basic case where we had a 35-year-old female patient who came to us with low back pain with radiation down 2 months. She had tried conservative management. It is just not getting her relief. She's a young person. She's a working professional. She wants to get back to her life. So what do we do? In that kind of a patient, on an MRI, we found out there is an L4, L5 posterior intervertebral disc prolapse. Now, one more thing which I would like to draw your attention is the red flags. Now, this is something which I would like to talk about, is that when we start our practice in pain medicine, we are very enthusiastic, but at the same time, we have our own limitations. We are able to take care of a lot of things, but there are certain conditions where, as good pain physicians or medico-legally or ethically, we are not supposed to do anything, and the patient needs to be referred to a specialist. And one, for example, in this case, what would be the red flags? If we have infection, whether we have inflammation, whether we have malignancies, then if the patient has got motor weakness. So if there is motor weakness, the patient goes for a surgical management. If there is malignancy, the patient needs to be referred to an oncologist, where his pain, beg your pardon, his malignancy, it is taken care of. So that is there. So what we can do for spinal pain now, basically, very broadly, what we basically have is, we have got three major pain generators. It can be either because of the discogenic pain, it can be because of facet, then there can be a ligamentum flavum hypertrophy, which is compromising the central and the lateral canal. So accordingly, we have got interventions which target the disc. We have interventions which target the facets. Then we have got interventions which target the ligamentum flavum. Then we also, because all of them are compromising the foramina and eventually leading to a sort of a compression on the radiating nerve, the nerve which is coming out. So it causes an inflammation on that part, and we can do a root block. So we can introduce steroids through the transforaminal route, through the interlaminar route, through the caudal route. We can go for an intra-articular facet joint injection. Then we can go for a median branch block, the SI joint block, the caudal epidural, and the interlaminar epidural. Now, radiofrequency ablation. As you get in touch with pain physicians, you will realize that even your Dr. Lija also comes from an anesthesia background. And as anesthetists, we have got love for the nerves. We are in awe of the nerve. We have a crush on the nerve. So whatever happens is, whenever there is pain, which we which we know is coming, we tried everything, it is not working. So what we do is, we just identify the nerve. And if there is a sensory, if it is a pure sensory nerve, we have hit the jackpot. So what do? We just go there and block it. If there is pain relief, then on the second sitting, we can actually damage the nerve. We can damage it by radiofrequency and by chemical neurolysis. So the same goes here. So facet joint supplied by the median nerve. So if you have got a pain which is coming from the things which is responsible for it is the median nerve, we block it, patient gets relief. The next day, we knock it off by radiofrequency. For disc, we are doing a lot of things like ozone discectomy, laser discectomy, hydrodissection, and even endoscopic discectomy, etc. Now, these are the fluoroscopic images. Now, as I told you, that all the interventions to increase the precision, we are using some sort of an image guidance. And most commonly, what we are using is either fluoroscopy or ultrasound. For spine, mostly we are using fluoroscopy. Along with that, you will also see few things like this. Now, what is this? This is, we are just trying to be doubly sure by injecting a dye. So firstly, we enter the space using imaging and then to be very sure that we are at the right spot, we inject a dye. Because the dictum is, where there is dye, there is going to be drug. So once we have confirmed, then only we inject. Now, as you would appreciate, we are taking a lot of images. This is an AP image. This is a lateral image, which we are taking care. Fine. Now, these are various interventions. This is for the disc. These are the root blocks. This is again the disc. This is the facet joint injection, and this is the SI joint. Once we have identified, then we can go ahead. Excuse me. Now moving on to the second case. Now this was an international footballer who came to me with a lot of knee pain, which he had on field, and on an MRI he had a partial ACL tear. Now again, in this kind of patient, conservative management was tried, but again he is an international player. He wants to go back to the field and perform, and so what we did was. We tried rehabilitation, didn't work. So what do we do next? Surgery? Not really, because that gives him a what do you say, a longer rehabilitation time, and he wants to be field. In fact, he was one of the players for the ISL, the Indian Football League. So what we did was, we proposed PRP. Now, PRP is a new interesting thing, not very new. It has been with us for now around 4 years, and it is a part of a regenerative medicine where we are using the body's own properties in repair. Fine. And we get these cells from various sources. One is blood, which is called the platelet-rich plasma. We can also get it from bone marrow. We can also get it from fat cells. Our process of injecting remains same. Only thing is the processing becomes different. So for example, the easiest to process is the blood. So we take out blood, we do a dual centrifugation, we get a platelet-rich plasma, and that is what is injected. When it comes down to bone marrow, we take out bone marrow, process it, and we do process it, and again injection is same. For taking out stem cells from adipocytes, we need to do a liposuction, then processing it becomes it. Why PRP is more common? It is cheap. It can be done in an OPD setting, in an outpatient department. So and we started around 4 or 5 years back, and from that time it has been quite an interesting journey. So what do we have after dual centrifugation is this, which is a platelet-rich plasma. So from when we take around 18 ml of fresh blood, mix it with ACD, so we get around 4 to 5 ml of platelet-rich plasma. Now, where we can use platelet-rich plasma, all the tendinopathies, right from shoulder to the heel, we can use it at every places. What we have generally seen is for inflammatory and tears and everything, it is a good medium for repair. Where it has got its limitation is degenerative conditions, something like knee, something like AVN. There are data is still not good, but yes, there is a lot of scope, and this is something, a thing for the future. Now these I have been part of a few international workshops. This was IASP World Congress in Boston 2018, and this was in Bangladesh where I was trying to talk about PRP. Now what you will realize is that here we have started introducing ultrasound. Now ultrasound, MSK ultrasound for a very, very long time it came into anesthesia per se, and we were using for anesthesia and acute blocks. But this part of using it into what do you say, for treating it has come out quite around 2 to 3 years, where anesthesiologists have started doing rather than nerve blocks, going inside the joints, going inside the spine with the help of ultrasound. So this is just refining it, and even we are now able to do dynamic examination of the joints when it comes down to diagnosing the tears. Now, this is again, I said that we can do it either when we are doing it in the knee. So either we do it fluoroscopically, or we do an aspiration of the synovial fluid to be very sure. We can inject the dye, or we can use an ultrasound. Fine. So let's move on to case number 3. So again, 75-year-old patient, OA knee. Now you can see the amount of comorbidities that she is having. And with these kind of a comorbidities, she carries a very high risk. And these kind of patients are somewhat not comfortable going for an OA, for a TKR. And so what do? They have come for us with pain relief, and we try to give them a better quality of relief. So as I told you, our fascination for nerves. So we identify the nerves, and luckily enough, the knee is supplied by some genicular nerves, which are pure sensory nerves. So what we do is, again, a 2-sitting procedure. Firstly, we just go ahead and block the nerves by local anesthetic, see how much relief the patient is getting, and whether the patient is comfortable post-procedure for 4 to 6 hours till the effect of the local anesthetic remains. And once that is done, we go ahead and do a radio frequency. Now, this is a cool tip. This is the latest model, or a cool tip radio frequency machine, which we started in 2018. There are some technical difficulties. If somebody would like to ask, I will be more than happy to talk about it in the discussion part. Now, most of whenever we discuss about pain, people tend to think that we only talk about pain when it is with the spine or the joints. But my dear friends, we have a bigger horizon. So this is a female patient diagnosed with migraine, not responding, developing side effects to medications. Can we help her? Yes, definitely we can help her. How do we help her? By giving Botox, by giving nerve blocks, by giving ganglion blocks, and we can give even by occipital nerve block. Now, interestingly, why I would just like, and Dr. Philip will recall that the few initial these nerve blocks we were using for some other indications by one of our more dear seniors, Dr. Rakshay, where we were using these for scalp blocks. This is a part of a scalp block. So these are the supraorbital, supratrochlear, and occipital nerve blocks, which are very simple to give but are extremely effective in patients who are suffering from this migraine. So the teaching that we get during our postgraduate actually helps it. Only thing, we need to apply it in the right subset of patients. So now this is Botox and trigger point injections that we are giving. Now this is we are giving a ganglion block, which is a trigeminal ganglion block given for trigeminal neuralgia. It is one of the most satisfying interventions because for all the interventions, the effect will start coming after some time. But for these kind of conditions, the effect starts coming right post procedure. So the post procedure, the patient comes with us with debilitating pain, severe pain, but walks off pain free. Now that is extremely satisfying as a pain physician. Now this is cervical. This is a case of cervical radiculopathy, where we just gave a simple cervical interlaminar epidural. Now cancer pain. Now with Dr. Lija, I think I will be briefly touching about. She would be doing most of these interventions in your institute. So what we basically do is we try to find out the sympathetic nerve supply or the autonomic nerve supply of the area which is being involved. So if it is an upper, we go for stellate ganglion. For upper GI malignancies, we go for celiac plexus, lumbar plexus block for pelvic and lower limb malignancies, and one special mention for Buerger's disease. I can tell you it is a limb savings intervention. The patient, if it is a classical Buerger's with good collaterals, if lumbar sympathectomy given properly and the patient stops the tobacco use, the patient responds so beautifully that eventually the part which is viable, it just goes into auto amputation. And I happened to work in one of the centers in Rajasthan, which was endemic Buerger's because of genetic factors and tobacco use. It is the most satisfying interventions because it is eventually a limb and sometimes a life-saving intervention. Simple to do it. Everybody can do it. Is some technicalities, but good results. Then you have for malignancies, for pelvic malignancies, you have superior hypogastric plexus block and ganglion impar. Now, ganglion impar also takes care of conditions like coxodynia and vulvodynia. Now, this is a patient who had a fall, typical osteoporotic fracture. And what do? We go inside and put in a cement, what we call it as vertebroplasty and kyphoplasty. The basic difference is in vertebroplasty, we are just going inside and putting in the cement, whereas in a kyphoplasty, we go inside, inflate a balloon, create some space and do it. We go inside and deposit the cement. So now that is kypho and vertebroplasty. Now this is the post-procedure pictures, and you can see what we do is we mix dye in the cement, and therefore you get this fluoroscopic images. Now moving on to the last question, last case discussion. Now this was a typical case of severe neuropathic pain after a gunshot. So the person had a gunshot in his spinal cord, because of which there was intense burning sensation which was not responding to the conservative treatment. And what did we do? We implanted a neuromodulator, which in the form of went for neuromodulation, and what we did was we put in a spinal cord stimulator. Okay, I will just try to give you a brief idea about what is neuromodulation. So basically, and you will realize that all of us have been using it somewhere or the other. For example, if your kid falls down or you fall down, you have pain. So what do? We just tend to rub it. So what are we basically rubbing it? So you have to understand it by the simple pain gate theory. No, there have been a lot of research and there are a lot of things, but to just give you a simple perspective, so there is a pain gate theory. So there is a gate through which only one thing can go. So what happens is, if you have an injury, the pain is going fine. But once you rub, there is another sensation which is going through that gate. So once that other sensation goes through that gate, the pain is not allowed inside. So what is the job of this machine? The job of this machine is just to create those sensations where we can cheat the spinal cord, and rather than the painful stimulation going on, the other sensations, the vibration sensations which are produced by these leads and this generator is taken care of. Now, these are more specific neuromodulator techniques where we are able to target the DRG. We can even, for sacral pain, we can use sacral nerve stimulation. And then there is an intrathecal morphine pump. So what we are doing is that when we have patients whose morphine requirements goes very high, who still have life expectancy, then what we can do is we can implant a catheter right inside the spinal cord, put in a pump with morphine, and reduce their requirement of, almost cut down their oral morphine, and we start with an intrathecal morphine. And all these things are externally programmable, and this pump also can be filled externally. Okay, so now these were the few things, the few interventions that we talk about. Apart from that, what I realized in my 10 years is that there is a very strong psychological component associated with chronic pain. And somewhere the patient is not comfortable going to a psychologist for their pain relief. And that is the time we as pain physicians have to step in. Now, this is something, basically taking baby steps, I have been started doing these psychological interventions for the past 1.5 years now. So the easiest thing to do is a cognitive behavioral therapy. Giving you a brief is that once you feel something, then you think about it, and then you react. For example, in a nutshell, so if I say an abusive word to you, you will feel bad and hit me. Okay, so what this talks about is, so if you have a pain, you go into a negative frame of mind, and those things reflect in your behavior. When we talk about CBT, so what we are trying to do is, what they said is, though all these things can be changed, but the thing which is most difficult to change is how you feel. So what we cannot modify what easily is what you feel, but how you think about it and how you react is something which can be trained or which can be manipulated. So that is the basis of this intervention. Okay, very interesting thing, easily can be done. If you have time, just go read about it. It is very simple to do and follow. Now we talked about the patients, the numbers, all the gambit of things what we do. So what is holding us back? What are the challenges? Now with that, what happened was, I talked about this survey that we had, a telephonic survey, and which we did a telephonic survey, and the results were quite interesting. So now what happened is, we called and asked them patient, so are you aware of the pain specialty, pain clinics or something like that? And 99% of the patients said that they were just not aware. Whereas in USA, the number is around 62. So there also the number is quite less. So definitely in India, what is lacking is there is an extreme low awareness of pain management as a different specialty. Now, that is one. So you have a condition, you have a situation where the popularity is low. Now in India, which is a typical example, is that around 30 to 40% of the patients do not go to, only go among all the patients suffering from chronic pain, only 30 to 40% of the people actually visit allopathic doctors. So there is awareness is low. Then you have majority going to a non-allopathic doctors. So what do we do? But now the situation looks grim. But what is on this survey? We got a lot of positive, few positive things also, where they said that if if you come to know that there is something like a pain department or a pain clinic, would you or your family, would you like your family to go there, or you would like to suggest? And 72% said yes. So there is hope, or there is light at the end of the tunnel. What are the positives? They say, why would you like to do this? Most of them said that it is a facility just there to take care of my pain. It is non-surgical, no hospitalization, and caters to multiple pain types. So therefore, what is basically required is more and more awareness, and it has got a high potential among patients. So there are n number of opportunities. It is up for grabs. So my dear friends, impressionable minds, impressionable age groups, just take up the challenge and bring it on. And it is a challenging field, but quite interesting. Now this is my email. So if you have any queries regarding any sort of opportunities, I will be more than happy to help each one of you. Now these are the few of the pictures of my centers. With that, I would like to, this is our team of doctors. So I stand here representing all of them. And thank you so much for your patient hearing. I think I exceeded my time.
Thank you, Dr. Dhruv, for that comprehensive presentation. And you've really opened our eyes to the various modalities of pain management which is available, which even among the medical fraternity, many of the doctors are not aware of all these options which are available for
Definitely.
managing pain. And
now
now
totally. Now the challenges, what I feel is, based on my talks, is for general population, they are just not aware about pain medicine. When it comes down to medical fraternity, their knowledge is that we just go for steroids. So my topic in those when I talk to those kind of doctors, I always tell pain medicine is beyond steroids.
Yes.
So now when I started off, it was say 99 to 100% of steroids. In decade, now I have gone down to say around 60 to 70%. So it is beyond steroids now. So that is one thing which I always emphasize on any platform whenever I'm trying to reach to my medical colleagues, that there is a lot of things which have come up and which are coming up, which are beyond steroids. So we should not be labeled as doctors who are just putting in steroids left, right, and center. Thank you.
The floor is open for questions. If anybody has any questions, they can ask now.
Dr. Dhruv, we've got a nice note from a student. Let me just read it out to you.
Sure, sir.
Thank you, sir. It was such a wonderful class. We learned a lot of things we were really unaware of, but which presents immense opportunities for a better life.
Definitely, sir.
This is one of our students.
Thank you so much, sir.
So, yes, Philip.
Yes,
Dhruv.
sir. How are you, sir?
I'm good, Dhruv. Really nice to meet you on this platform.
Yeah, sir. Finally, we met.
And really nice to see you in the new getup.
Thank you so much, sir.
Very good. So, have you felt like any difference in the kind of patients? I mean, the tolerance level amongst patients. Like in the UK, people have a very low threshold to pain, or to any untoward incident, they will break into tears, or they cannot take it at all. So even a slightest pain, it will seem like a big issue to them. But in the Asian subcontinent, probably we are trained to accept more and tolerate more. If they are, again, it's subjective. So it takes a while for us to say, no, I am in pain. So have you felt any difference in the kind of...
Definitely, sir. Sir, I'll tell you one simple example which I often quote. Excuse me. If I often quote, see, the thing is, and when I'm talking to a general public, when we have the biggest superstar of India, telling and talking about dard mein bhi koi baat hai. There is an ad by Amitabh Bachchan. We said dard mein bhi koi baat hai. So that is the cultural mindset. Then cultural mindset, like, now that is gender specific. For example, males don't cry. So that alpha male kind of a situation will not allow us to express that pain. That is one. Secondly, for females, they will have a social obligation that post pregnancy we are going to face pain, post menopause we are going to face pain. So because of that bias, we are just not open about expressing pain. So therefore, now that is second. Third thing is, sir, you will also agree, in Western population, their medical is covered. They even get a disability benefits. In India, even we, the cream and cream of our doctors, we are also in a way a daily wage workers. So even if we don't work for 4 days, we will start worrying about our jobs and other things. Therefore, that also prevents us from expressing our pain and seeking medical services, because it goes from our own pocket. So for example, a laborer will have to forego of his 1 day's wage plus the added cost of the medical services. That is why we just tend to ignore that, we tend to ignore a lot of conditions, and pain is the last thing on their priority list. So these are the cultural things and the financial things. um, what I have seen. Along with that, when I interact with young doctors, I always tell them, we study a lot of Western books where they talk at length about patient malingering and for untoward benefits. But in India, believe the patient. There is a very small subset of patients who will walk into your OPD and say, "Ki boss, they might be faking pain." They are in pain. So believe the patient.
Right.
And that is why what I think Dr. Lija is also working in that field. People, because of that mindset and because we ape the West, for example, morphine. Now, availability of morphine has gone down so dramatically low that now getting a simple ultra set is a big ask. Just because we are aping West, left, right, and center, because they had an epidemic of opioid epidemic, it has cut down. And between states, it is crazy. And I have patients like in Punjab, because of the crisis, they have to come down all the way to Haryana or Delhi to get a simple dose of tramadol, ultra set, or not a full dose tramadol. So I totally agree, sir. Culture does play a very important part when it comes down to expression, the management, and the treatment of pain, sir. Excuse me.
How affordable are these procedures?
Sir, very affordable. I tell you a basic, I'll tell you a basic thing, sir. What we are using is, in a spine intervention, we are using two 2cc syringes, one 5cc syringe, one 10cc syringes, 2 vials of depomedrol, one spinal needle. If you are planning an epidural, one epidural needle, 2 ml of what you say, 2 ml of dye, Omnipaque dye, and some saline and local anesthetic, and an OT CM compatible table. Rest everything is your procedure cost. Actuals are genuinely very less. Apart from, see, if you go towards radio frequency and all those stuff, yes, it is a costly affair, but then probably the cost goes up. But even for PRP, now the PRP cost would be, a kit would cost around 2,000. The machine is around 1 lakh. So you can do a PRP sitting for say 3 or 4,000.
Okay.
So not very costly, but yes, the pumps and the everything which I discussed on the later part, yes, those are goes into lakhs. That is lakhs. But rest, it is affordable for the common population. It is affordable. So that is why I say, if we take pain medicine to the masses, see, I work in an urban center most of the times. Do I travel to the interiors also? But there they have an option. So I have to discuss, boss, if you go for a surgery, this is this, and if you go for an intervention, this. Cost is not an issue for most of them. But so therefore you can discuss the option of surgery. But if you go to a rural part, the Rajasthan, I travel to, I am a consultant at basically and mentor to a place in Bhilwara. There, the kind of people that come to my OPD, you cannot think about telling them around a 50,000 procedure or surgical cost. They do not have enough to wear. So how can you expect them to go for a surgery? So you have to do something to make them more mobile, more productive. Excuse me.
Right. But the quality of life that someone gets after the pain relief is amazing. I mean, you see wonders after the pain is taken off.
So, yeah, so the point is, what we need to understand, we need to tell to the patient is that prognostication of the patient is very important. We are not gods. If you have a spine of a 70-year-old, I'm not going to make it 40-year-old. What I'm going to do is I'm going to take care of your pain so that the acute pain settles down. Then you start with your exercise, your walks, and lifestyle modifications. I have got crazy bunch of people who said that you gave me an injection in the knee and I want to squat and do a puja while I'm sitting. Mega boss, that's not going to happen. Fine. So those fine, if what I have seen is, if the patient is ready to do those modifications religiously, then they have a better chance of recovery. And what we are looking for is an improved quality of life. For example, pre-procedure, if the patient is not able to take 10 steps to the toilet, now he can comfortably go to the toilet, go to the what you say, community center, go to this. He should be happy, and so should I be happy. Okay. But if he says, no, I want to travel to the Himalayas and do a parikrama at Mathura or go to some other place, that is not going to happen. So those where the patient has got a realistic expectations, there we can do wonders.
Right, I take the point.
Fine, sir.
You mentioned about intrathecal morphine pump implantation. So can you explain in which group of patients and where it is indicated?
Ma'am, see, the thing is, there are two subset of patients where we can. So first and basic criteria is the pain has to be opioid responsive. Okay. Now these are two subset of patients. One subset of patients is, say, for example, cancer. But in cancer, because it's costly, so it would be around 5 to 6 lakhs. So what we do is the life expectancy has to be more than 6 months. Then only it becomes viable. Okay. So if you have a pain which is opioid responsive, life expectancy more than 6 months, then you can go ahead. So what we do when we do this is we do a trial. So firstly, what we do is we do either an epidural or an intrathecal morphine test dose, preservative-free morphine. We just inject it, minimal doses, or sometimes you can use fentanyl also. Basically, an opioid is injected into the intrathecal space or an epidural space, and see how the patient is responding. Once the patient is responding to, there is a significant reduction in pain. What we define as significant is less than 50% pain relief. In that subset of patients, we go ahead and implant it. Okay. Sometimes what happens is, we have also done it in patients who have got failed back surgery syndrome, who have got 7, 8, 10, 12 surgeries of spine, and they are on a very high dose of morphine. So because of, you will also agree that after a certain level of morphine, their functionality deteriorates. They are not able to work. They have constipation and all those things. So what we do is, in order to reduce their dependence on morphine and cut down their dose, we go for an intrathecal dose. The same procedure is followed there.
So is there a maximum dose of oral morphine which you tell? Is there a cutoff like that?
No, ma'am, it all depends. It all depends on the patient.
Oh.
If the patient is tolerating that, but obviously not on a minimal dose. Say if the requirement is, say, 40 milligrams per day, we do not advise an intrathecal morphine pump. So if it is around in say 60, 70, 80, 100, that would be the time where we ask them to do this. And when we do it, again, the same procedure is followed. We go for a test dose, and based on the response of the test dose, we go ahead and do it.
Are there any more questions?
Yes.
Yeah, please.
I'm Dr. Ajit. I'm a palliative physician.
Yes, sir.
And your presentation has made us aware of some of the options available in the interventional pain therapy, and some of them were new to me, very new. And in one of the case scenarios, you mentioned about migraine pain management, and you mentioned about botulinum toxin injection and some other procedures. I just want to know something more about this botulinum toxin injection. how safe it is, and how long will the effect of one injection last, how cost effective it is.
See,
I
the
just
thing
wanted
is
to.
very interesting thing, sir. So now, sir, for Botox, it is an absolutely safe thing. The side effect is actually a good effect. The side effect is that all the wrinkles on the face and everything will go. So there are basically 31 sites on the basically on the muscles, basically the facial muscles, where we inject it. 5 international unit is injected on these sites. If you want, I'll share you the slides on the video also of us doing it. Costing would be around we generally we are using around 200 international units. So the costing would be around somewhere around 35 to 40,000. Effect would last around 6 months. Fine. Again, as I was talking to Dr. Lija, now that is reserved for patients who have either stopped responding to drugs or who have started developing side effects or who are just not able to tolerate the medicines. So those subset of patients, for example, yesterday I did it for one of the medical students. So what happened is that he is doing some entrance exam and the drugs make him caused a lot of drowsiness. So he said, give me Botox so that for the next 6 months, I'm totally off medicines and then we can do it. We can repeat it also, sir. So there is absolutely no side effects. It is a simple intramuscular injection, which is given by a hypodermic 1 ml syringe. And you can do this. And off the record, if you start doing it, you can do it for other cosmetic reasons also, because you get more comfortable. Now, because we are on the topic of Botox, sir, we are also using Botox for another subset of patients, not purely a pain conditions, but that is for spasticity. So for example, if we have got a CP kid of cerebral palsy who is spastic, we can actually do these Botox injection and weaken the small muscles, and then with physiotherapy, the patient rehabilitates beautifully. I've had few patients who were like 1 year or 2 years who were brought to me, and now they have been gradually with a multiple Botox injection and certain nerve blocks. They have start going into schools. They are lacking, but still they are working. So that is another one good use of Botox in pain medicine, or as you call it. Regarding so for some people who are just not able to afford Botox, so what we can do is we can do a nerve block. So what we are generally blocking the supraorbital, supratrochlear, and the occipital nerve block. Fine. So these are the few things. One thing which I sometimes what happens is it is a mixed picture. So you are not able to understand whether it is a migraine. Along with migraine, we also take care of, sir, excuse me, a cluster headache. Now in cluster headache, intervention of choice is a sphenopalatine ganglion. So now that can be done intraorally by the external approach, or we can go for an internal approach through the fossa, pterygopalatine fossa. So that is another which I had mentioned. So that is also we do. Then for a very few rare cases where the patient had severe occipital neuralgia, we can block the nerve, do an RF ablation. Not many cases, probably 2 or 3 cases I have assisted where we had to put a peripheral stimulator, something like nerves to the neuromodulation technique which we had used. But Botox, nerve blocks, definitely we are using, and it is a very good result, sir. Even the evidence is there. Nerve blocks again are quite cheap, which can be done. Botox, obviously, the cost is an issue, but technically it is not difficult. What I meant to say.
Okay, thank you.
No problem, sir. Fine.
Are there any more questions? So, good knowledge of pain pathways, pain mechanisms and types of pain, and a thorough assessment of the patient. These are the keys to effective pain management. So thank you, Dr. Dhruv, for passionately bringing out these points in your presentation. We really enjoyed it. A lot of information, and you're all enlightened.
Thank you
So
so
thank
much.
you so much. And I would like to hand over the session to Dr. Jacob.
Thank you, ma'am. Dr. Dhruv, that was indeed an amazing session. As ma'am said, you've really chartered into unexplored waters. I mean, most of us didn't know a lot of things which you shared, and really, really grateful for that. It was really an amazing session. Thank you for sparing your time and coming online and giving this wonderful talk to our institution, our students, and our faculty. Thank you so much once again. Looking forward to more sessions from you on different aspects of pain management.
Sure, sir. Thank you so much.
Thank you so much. And Ligia ma'am, thank you so much. I know that you're just after your shot and you're tired after your COVID vaccine, and extremely grateful to you for taking the pain and coming over and ably moderating this session. We're extremely grateful to you too. And all the participants, students, faculty, and the rest of you who have joined in. I hope this session was really, really useful for each one of you. Looking forward to see you tomorrow. We have one more amazing session. This is on personalized care for cancer patients. One medical oncologist from Calcutta is talking to us on this particular topic, and it happens to be World Cancer Awareness Day. So looking forward to have you all for that program as well. We start at 7 p.m. And so on that note, signing off from Believers Church Medical College and Hospital. Thanks again to our special speaker, Dr. Dhruv Bibra. Sir, looking forward, and thank you so much. Thank you so much. Thank you, ma'am. Thank you, everybody. Have a good evening.